Hi, welcome to the Diabetes Virtual Education Summit presented by Johns Hopkins University School of Medicine at CardioCare Live. My name is Dr. Tom Donner, and you're tuned in to a live session called What Works for Type 2 Diabetes and Associated Obesity. I'm an associate professor at the Johns Hopkins University School of Medicine and director of the Johns Hopkins Comprehensive Diabetes Center. Before we get started, I'd like to remind our audience that I will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. So my presentation today is going to deal with what works for type 2 diabetes and associated obesity. My objectives will be to discuss the association between diabetes and obesity, review various approaches to reduce obesity in diabetic patients, and present some of the benefits, risks, and outcomes of bariatric surgery in type 2 diabetes with morbid obesity. And I have no relevant disclosures. So this photo shows quite dramatically what has happened with rates of obesity in the United States in the past 2 decades, in this case between 1991 and 2000. On the left-hand side of the slide, in 1991, these estimates were done through telephone surveys of 200,000 persons in the United States, and it shows an obesity incidence of 10 to 14% in the majority of the population. If we move the time forward 9 years, the majority of persons in the United States now have an obesity rate in the greater than 20% range. This is a 61% increase in just a 9-year period. And this mirrors very closely what happens with the prevalence rates of diabetes in the United States. So again, in 1990, the majority of the US population had a diabetes incidence or prevalence of 4 to 6%, and moved up to 2000, 10 years later, the large majority of the states had diabetes prevalence rates of greater than 6%. Almost a 50% increase in the rates of diabetes. If we move the clock up to more current time, we now have an obesity prevalence in the United States upwards of 36%. This is higher in minority populations. Hispanics and non-Hispanic blacks have higher rates than non-Hispanic whites. And this is mirrored by higher diabetes incidence rates seen also in minority populations with the highest rates in non-Hispanic blacks. So there, in 2000, the diabetes prevalence in the United States was up to 8.3%. The rates in children is still relatively low, but this is a worrisome population. 10 to 20 years ago, it would be unheard of to have persons develop type 2 diabetes before the age of 20. Now it's not uncommon that we're seeing children, even in the early teenage years, who have type 2 diabetes present at that time. So there's a clear relationship in the pathogenesis between obesity and diabetes. We think that this predominantly is due to increases in visceral obesity that's occurring at younger and younger ages. Visceral obesity leads to insulin resistance and insulin deficiency. Visceral obesity is responsible for inflammatory adipokines and cytokines, and reduced levels of adiponectin. Adiponectin is a protective substance. It increases the oxidation of free fatty acids and decreases hepatic gluconeogenesis. We know from high free fatty acid levels that we also get ectopic fat deposition in the liver and skeletal muscle, and this deposition of fat leads to increased insulin resistance. And free fatty acid deposition in islet cells of the pancreas lead to decrease in islet cell function and a decrease in insulin secretion. There's also been shown to be significant mitochondrial dysfunction in both muscle and islet cells, again leading to insulin resistance and decreased insulin secretion. And there's a strong feeling that genetic factors which lead to type 2 diabetes probably predispose also to obesity. So, why worry about glycemic control in patients who aren't dramatically symptomatic from hyperglycemia? On the right-hand side of this slide are 2 studies, which are the longest studies that have looked at more intensive control in patients with type 2 diabetes. The Kumamoto study, which was a 6-year study, whereby patients were randomized to standard control and their A1C was kept around 9% for the 6-year duration of the study, versus those who were more intensively controlled and their A1C was kept at 7% for the duration of the study. And in the more intensively controlled population, the incidence of retinopathy was reduced by 69% and nephropathy by 70%. On just to the left of that, the DCCT was a trial in type 1 diabetes around the same duration of time, and you can see that the improvements in A1C was very similar in the more intensively controlled population, that the improvements in retinopathy and nephropathy mirrored that seen in the type 2 population. And we feel this is because the mechanism of these complications was similar in both populations. These are directly complications related to uncontrolled glucose levels. On the right-hand side, the UK PDS study was done in more recently diagnosed patients with type 2 diabetes. And they were randomized to more intensive control, where the A1C was achieved was 7%, versus standard control, where the A1C was 7.9%. And these patients were followed for a longer duration, for 10 years. And because of the lesser difference between the two A1Cs, the improvements in retinopathy and nephropathy was somewhat and proportionally less. Macrovascular disease, there was a 16% reduction that didn't quite meet statistical significance. When these patients were followed for an additional 10 years, the reductions in heart attack rates, stroke rates, and myocardial infarctions and death were significantly reduced. So why is this important? Well, diabetes remains the leading cause of blindness in the United States, leading cause of end-stage renal disease, and leading cause of amputations in the United States that were non-traumatic. And these complications are to a large degree preventable. When you take the UK PDS data and adjust that for a 1% decline in hemoglobin A1C over a 10-year period, you'll see that the myocardial infarction rate is reduced about 14%, stroke rates by 12%, and all-cause diabetes deaths, diabetes-related deaths by 21%. These were all statistically significant numbers. So this is a patient population that is largely overweight and oftentimes obese. So when we target their therapy for their diabetes, it would be useful to have interventions that would additionally lead to weight loss, given all the complications of obesity. And so one question becomes is how can we achieve A1C targets while achieving weight loss? The Look Ahead study was started in around 2003, and this randomized many thousands of patients with type 2 diabetes, aged 45 to 74, to either intensive lifestyle intervention versus a control population that received standard diabetes support and education. The intensive lifestyle intervention group targeted a weight loss of 8%. They were instructed to work up to 175 minutes of moderate intensity physical activity per week. They were given very strict dietary guidelines, including reduction in the fat content of their meals to less than 30% and a reduction in saturated fat to less than 10% of their total caloric intake. Those who weighed less than 250 pounds were targeted to a caloric intake of 1,200 to 1,500 calories per day, and if they were greater than 250 pounds, to 1,500 to 1,800 calories per day. And as part of their dietary program, they received replacement meals, either 1 to 2 per day, and also meal plans to assist them with achieving the caloric goals. And at 1 year, the intervention was pretty successful. So the weight loss was 9 kilograms in the intensive lifestyle group versus a little less than 1 kilogram in the diabetes education only group. Waist circumference reductions mirrored the loss in weight, and there were good reductions in fasting glucose levels, a 0.7% reduction in hemoglobin A1C, not bad given that the baseline A1C was about 7.3%, And that's about what one would expect with one of the oral anti-diabetic agents that we use in the treatment of patients with diabetes. There are also cardiovascular benefits in terms of reductions in LDL cholesterol, triglycerides, and a modest improvement in HDL cholesterol and reductions in CRP that were seen in the intensive lifestyle intervention group, much more so than the diabetes support and education group. When this patient population was followed for a total of 4 years, though, you can see that it was difficult to maintain weight loss that was achieved at 1 year. And this has been seen in a number of different lifestyle intervention programs over the years. So at 1 year, the intensive lifestyle intervention group had lost 9.3% of their initial weight, and then this waned down to 5.2% at year 4. And these changes were seen regardless of the age or ethnicity or the gender of the population. So typically, when oral agents fail, when lifestyle measures fail, diet and exercise fail, and we're unable to achieve a target A1C of less than 7%, we typically turn to medications. And we have a large number of medications that we can choose from today. In the middle column, you'll see the expected reduction in hemoglobin A1C, insulin being the most efficacious drug since there's no upper limit in the dose, and regardless of the starting A1C, we can get A1C levels down significantly, upwards of greater than 2.5% in patients who are quite uncontrolled. Sulfonylureas, repaglinide, nateglinide are insulin secretagogues that also have good efficacy in reducing hemoglobin A1C. Metformin, another good potent agent, as are the thiazolidinediones. The alpha-glucosidase inhibitors and DPP-4 inhibitors are somewhat more modest in their effectiveness of lowering hemoglobin A1C. And the latest class of medications, the GLP-1 agonists, are, again, a much more potent anti-hyperglycemic agent with A1C reductions approaching 1.5% or greater. In the right-hand column, you'll see that the majority of the agents will either cause no weight change or an increase in weight. So typically with insulin therapy, we'll see a weight gain, and patients appreciate that after they're starting insulin. It's one of the barriers to insulin therapy. The weight gain to some degree has to do with rehydration. So many of these patients who are quite uncontrolled come in dehydrated, and so becoming rehydrated with better glycemic control contributes to some of the weight regain that you see. But clearly insulin therapy associated potentially by stimulating appetite to some degree can lead to weight gain. The sulfonylureas, also there's a small weight gain seen. Repaglinide and nateglinide, again another form of insulin secretagogues, you also see a small weight gain. The thiazolidinediones, pioglitazone and rosiglitazone, can have a significant weight gain in some patients who are treated. These are averages seen in studies, so the averages in these studies between 9 and 10 pounds on average. Some patients can gain much more than that. The alpha-glucosidase inhibitors and DPP-4 inhibitors tend to be relatively weight neutral versus a very small weight gain. And of all the agents, the GLP-1 agonists lead to the most significant weight loss, and we'll talk about that class in more detail in future slides. So for a number of reasons, and metformin is our first-line agent in patients who can tolerate the drug and patients who do not have significant renal insufficiency. It has a number of beneficial properties, and in addition to being a very effective glucose lower, it tends to lead to a modest weight loss. It tends to improve total and LDL cholesterol and lower triglycerides. It also improves the levels of a number of clotting factors, including PI1 and fibrinogen. And we think that because of these improvements, both in lipids and also in clotting factors, that's why it's been shown in the UK-PDS in an overweight patient population to reduce the risk of myocardial infarctions, strokes, and diabetes-related deaths in overweight patients more than sulfonylureas or insulin. And more recent findings about this drug were unanticipated initially, but there has been a reduced risks of a number of cancers seen with metformin use, including colon cancer and pancreas cancer, as well as in breast cancer. And in patients who have underlying cancers who are on metformin, the mortality is reduced. We believe we know the underlying mechanism for this. When patients who have type 2 diabetes are on insulin, it's been shown that the addition of metformin to insulin, by improving insulin resistance and decreasing hepatic glucose output, typically leads to a reduction in insulin dose upwards of 20 units per day, with an additional reduction in hemoglobin A1C and a modest weight loss. So something to consider in patients who appear to be needing a multiple insulin dose regimen for their control but are not on metformin. The addition of metformin would be expected to have improvements in weight. So now the GLP-1 agonist group, exenatide and liraglutide. So again, significant reductions in hemoglobin A1C are seen in the majority of patients who are treated with these agents. The weight loss that is seen is between 1.9 and 5.3 kilograms on average in these studies, and it typically is sustained. There are additional benefits and reductions in systolic blood pressure and in LDL cholesterol. There are increases in HDL cholesterol that is seen. The most common side effect is nausea and vomiting. And this is typically seen if too high a dose is started initially, or if a patient has been bumped up from a lower dose to a higher dose and they develop nausea and vomiting. Typically the symptoms will improve with a dose reduction. There have been rare reports of pancreatitis with the use of this class of agents. This appears to be real since the rates are higher than used with other classes of agents. This has been a little bit difficult to tease out since the pancreatitis risk is higher in patients with underlying type 2 diabetes, predominantly because these patients can have uncontrolled hypertriglyceridemia and also have a higher risk of gallstone disease, two factors that can lead to pancreatitis. However, when they look at retrospective claims analysis studies, they have not shown an increased risk of pancreatitis. So these agents are called incretins. So GLP-1 is a naturally occurring hormone secreted by the distal portion of the small intestine upon the ingestion of food. And these incretin hormones have a number of effects. They directly stimulate beta cells to secrete insulin in a glucose-dependent manner. And glucose-dependent means when glucose levels are not elevated, there's not stimulation of insulin secretion, and so one does not see hypoglycemia in these patients to a significant degree. There are also receptors for GLP-1 on alpha cells. Alpha cells make glucagon, and glucagon secretion by alpha cells is suppressed in the setting of GLP-1. And therefore, there's a decrease in glucagon secretion and reductions in hepatic glucose output. The stomach emptying is also slowed with these agents, and so by decreasing the delivery of ingested carbohydrates to the small intestine, there's a decrease in postprandial hyperglycemia. And finally, there are receptors for GLP-1 in the satiety center of the hypothalamus, which leads to satiety and reduces appetite. And typically patients will tell you that it's not that they don't have appetite going into the meal, but when they start eating the meal, that they tend to be satiated earlier and so eat less food at any particular meal. So a number of studies have been done showing the efficacy of these agents. This is the Duration 1 trial. This is with a weekly dose of exenatide, and it showed comparable efficacy in terms of lowering A1C, whether it was added to diet and exercise on the left, whether it was added to metformin, metformin in combination with a sulfonylurea, metformin with all other agents, sulfonylurea with all other agents, or thiazolidine diones and all other agents. And the A1C reductions that were seen were between 1.6 and 2.4%. And the reduction in A1C tends to be sustained, and so this is a 3-year trial, again using once weekly exenatide, where the reduction seen was 1.6% in A1C at 3 years from baseline. And the weight loss was also sustained, and at the end of the 3 years, the weight reduction in that group was 2.3 kilograms. I apologize for the busyness of the slide, but there are a number of studies that have been done with these agents compared to a number of other agents. We see very consistent reductions in hemoglobin A1C, and typically weight losses of between 2 and 4 kilograms. This is similar whether you look at twice daily exenatide or once weekly exenatide, or in comparison with once daily liraglutide at the bottom. So how about weight loss medications? And there have been a number of these over the years. Fenfluramine and dexfenfluramine were agents that were used many years ago, but were withdrawn from the market because of cardiac valvular problems. And a number of other agents have similarly been removed from the market due to a number of significant adverse side effects. The 2 agents that are available in the United States, actually the 3 agents available now, phentermine, orlistat, these agents have been around for a while. Phentermine stimulates the sympathetic, is a sympathomimetic agent, and has some issues with palpitations and increases in elevated blood pressure. These are characteristics that are not ideal in our patient population who have type 2 diabetes and are high risk for cardiovascular disease. And orlistat tends to be a less effective weight loss agent. There has been a drug that was approved a little less than 1 year ago, which is a combination of phentermine and topiramate. Topiramate is an anti-seizure medication which has some appetite-suppressing effects, and I'd like to discuss this agent in a little bit more detail. So this is a study that was published a couple of years ago, looking at the efficacy of the combination of phentermine with topiramate on body weight. And you can see that there are a pretty impressive reduction in the percent body weight loss of upwards of about 13 to 14% weight loss, and these are data followed out for 3 years, showing persistent weight loss in patients who stay on medication. And in the bottom graph, you can see that there is a dose-related improvement in the percent of patients who achieve a greater than 5% and greater than 10% weight loss. This slide shows that there are a number of benefits in terms of the cardiometabolic variables seen in patients who are overweight. And so in the upper left-hand side, you can see that compared with lifestyle alone in blue, that you see improvements in both systolic and diastolic blood pressure, and these are patients who are hypertensive. In the upper right-hand corner is the changes in lipids in patients who had hypertriglyceridemia at baseline, and in the far right you can see there's a significant reduction in triglycerides, and in the middle part of the graph an improvement in HDL cholesterol that's associated with the weight loss seen with this agent. On the bottom left-hand corner is the reductions in fasting glucose and in hemoglobin A1C seen in patients who had diabetes who were enrolled in this trial. And reduction in A1C about 4%, again mirrors the improvement in glycemic control that one would see with weight loss. And finally, in the bottom right-hand corner are improvements in both fasting glucose levels and reduction in insulin levels in patients who had prediabetes who were randomized to the active agent. The reduction in insulin levels seen in the setting of reduction in fasting glucose levels mirrors a decrease in insulin resistance that's due to the weight loss. So finally, I'd like to spend some time on the effects of bariatric surgery in patients for type 2 diabetes. There's been a great gain of knowledge on the effects of this intervention in the type 2 diabetes patient population. There are 5 main procedures that can be seen on the left-hand side. The Roux-en-Y gastric bypass is the most commonly used in the United States. These procedures are typically categorized either as malabsorptive or restrictive. And the Roux-en-Y gastric bypass, by causing a small pouch of the stomach, is to some degree restrictive, but also by having the food that enters into the stomach being delivered directly into the distal small intestine also is to some degree malabsorptive. We think, however, that it's not malabsorption that's leading to the significant weight loss that can be seen with this procedure, though, that it's to some degree mediated by the dramatic increase that we see in incretin hormones very shortly after the procedure is performed. So GLP-1 and GIP levels, the two main incretin levels, increase significantly after this bypass procedure is performed, and we think that's one of the reasons that we see a dramatic improvement in glucose levels shortly after the procedure is performed, even before a significant weight loss has occurred. So the other types of procedures that are done today are listed on the left-hand side, and you can see that these are either restrictive, it's primarily either banding, gastric banding or gastric sleeve, versus malabsorptive with the biliopancreatic diversion and duodenal switch procedure, which is predominantly malabsorptive and stimulation of incretin hormones. In the middle column, you can see the expected weight loss seen with these procedures, and this is the percent of excess body weight that's lost with the procedure. So with the Roux-en-Y gastric bypass, 50 to 70% of excess body weight can be expected to be lost after the procedure, and the weight losses are to some degree similar and to some degree less than Roux-en-Y gastric bypass with the other procedures. I'm going to talk a little bit about complication rates, and the rates are fairly similar between the different interventions, but obviously the malabsorption is going to lead to a need for vitamin replacement as part of the postoperative medical course. The cost of these procedures is listed in the far right-hand column. Right now, Medicare and Medicaid predominantly pay for Roux-en-Y gastric bypass and gastric banding in appropriate morbidly obese patients, and the other procedures are covered depending on the different insurance carrier. Interestingly enough now, because the procedures are now done much more routinely and much more safely, many of these can be done laparoscopically with much less operative morbidity and mortality, that we're starting to see that patients are doing well enough to the point that it becomes cost effective for insurance companies to be paying for these procedures. And we'll talk a little bit why, predominantly because many of the comorbid conditions that patients come in with, the diabetes, the hypertension, hyperlipidemia, all significantly improve following gastric bypass surgery. So this is a study that was published last year in Diabetes Care. This was Roux-en-Y gastric bypass surgery in patients with type 2 diabetes and mild obesity being defined as a BMI between 30 and 35. And one can see in patients who had diabetes resolve or had diabetes improve that the waist circumference and total body weight loss were significant with this intervention and followed out for 3 years. In these patients, hemoglobin A1C levels declined dramatically, and you can see on average that the starting A1C was quite high, upwards of 9.8% in these patients, many of whom were on insulin or multiple oral agent therapy. And the A1C fell rather quickly at 6 months and then plateaued out after about 12 months, down to an average of around 6%. And also there were corresponding significant reductions in fasting plasma glucose levels. And on the bottom left-hand portion of this slide, you can see that diabetes remissions were upwards of 88% in this population. Diabetes remission was defined as a hemoglobin A1C of less than 6.5% and no need for diabetes medications. So an additional study came out in New England Journal of Medicine this past spring, looking at patients who were obese and also had type 2 diabetes. You can see that BMIs were quite elevated at baseline, these were middle-aged patients and typically had a duration of diabetes 8 to 9 years, who were randomized to either medical therapy, to Roux-en-Y gastric bypass, or to a sleeve gastrectomy. And this figure shows the outcomes of the surgery. And so after 12 months of intervention, you can see that there was a reduction in glycated hemoglobin in the lifestyle intervention and medical intervention group, but not to normal, as opposed to Roux-en-Y gastric bypass and sleeve gastrectomy, in which the hemoglobin A1C came very close to the normal range. Fasting glucose levels were similarly mirrored in terms of reductions over time. This is a study that was also published just this past year in the Annals of Surgery. This was a study done in Spain, and they followed up 3 years patients who had undergone Roux-en-Y gastric bypass surgery who were morbidly obese. One could see that at 12 months, 3/4 of the patients had achieved remission of their diabetes. This was both either with Roux-en-Y gastric bypass or sleeve gastrectomy, which led to comparable remission rates of diabetes. They looked at factors that could predict who would be able to achieve a remission and those who would not be able to achieve diabetes remission. The longer the duration of diabetes, the higher the pre-surgical glycated hemoglobin level, the need for insulin therapy at baseline, and also a lower excess weight loss at 1 year predicted that there would be a lack of diabetes remission. In those who achieved remission, similarly, but had a recurrence of diabetes that occurred after the first year, insulin use before the surgery, older age, and weight regain after remission predicted a recurrence of diabetes. The adverse effects of gastric bypass tend to be those of malabsorption, so of protein, iron, calcium, vitamin B12, and vitamin D. So commonly, vitamin B12 and vitamin D replacement is needed, and in patients who need iron supplementation. Rarely, vitamin B1 deficiency can occur, but it's potentially serious, so this also needs to be tracked postoperatively. Uncommonly, one can have anastomotic leaks or marginal ulcers. Also, intestinal stenosis can be seen. These complications are relatively uncommon. As an endocrinologist, I will periodically see patients who present to me for postoperative hypoglycemia. And this has been found to be due to nesidioblastosis, a condition that we have become familiar with in young children who have hypoglycemia due to excess amounts of islet cells in the pancreas making insulin. So presumably in a type 2 diabetes patient population where they have beta cell hypertrophy, to overcome insulin resistance, to allow them to make excess amounts of insulin, that this to some degree persists after the surgical procedure of gastric bypass, and so by the time they lose weight and insulin requirements are not as high, when they become more insulin sensitive, that they can become hypoglycemic. This is typically postprandial hyperglycemia that's seen, and so our interventions are to reduce the carbohydrate content of meals, to increase the fiber content of meals, to help slow the absorption of carbohydrates, and to spread out their meals so they eat multiple small meals during the day as opposed to larger carbohydrate meals. This, by blunting the postprandial carbohydrate load, will tend to reduce the postprandial hyperinsulinemia and the hypoglycemia that occurs several hours later. We can also use agents such as acarbose, which slows carbohydrate absorption, and verapamil, which slows intestinal motility in these patients, but uncommonly, patients who have severe hypoglycemia may need to have the bypass procedure reversed, and sometimes we need to do pancreatectomy in these patients. So my own perception with bariatric surgery has changed over the last 10 years as we have seen the procedure now become laparoscopic with less surgical morbidity and mortality seen with these patients. Now that we have data showing the multiple benefits in this morbidly obese patient population, we will tend to suggest to the patient the consideration of gastric bypass, especially if their BMI is quite elevated and their diabetes can't be adequately controlled with lifestyle and medications. A recent meta-analysis showed a biochemical diabetes resolution in about 75-8% of patients who undergo one of these bariatric surgical procedures. The rapid normalization, as I alluded to earlier, in glucose levels appears to be stimulation of the incretin axis, especially GLP-1 secretion. And the long-term diabetes associated mortality has been shown to be reduced upwards of 92%. Obviously, that's the bottom line and something we'd like to see reduced. The 30-day mortality of bariatric surgery is now down in experienced centers down to 0.28%. So acceptable mortality in this very high-risk population. So with that, I will conclude the presentation, and I'd like to turn to questions. And so again, I encourage the audience at this time, if you have questions from this presentation, to go ahead and submit them, and I'd be happy to field as many as I can that we have time for in this setting. And so a question has come in terms of, with all these different options available to us, which should one choose at this point? So somebody with diabetes who is obese and has uncontrolled diabetes, which of these options should be sent? Should we send them for bariatric surgery right away? So a good question, and I think the bariatric surgical experience is good to the point now where it becomes much earlier in my consideration. However, I think that without giving lifestyle an attempt, I am not going to turn somebody to bariatric surgery for a number of reasons. First of all, some patients will see significant improvements in weight, in their glucose control, in the blood pressure, and lipids with changes to their diet, which sometimes can lead to a significant reduction in their caloric intake. So the diet that we typically recommend in our nutrition center is one that is reduced in saturated fat, one that is much higher in fiber content, both in non-starchy vegetables and in whole fruits, but also in the fiber content of carbohydrates, because high fiber diets lead to satiation and a decrease in caloric intake. Also, many of our patients are totally inactive, and physical activity, by improving insulin sensitivity, also not only will improve glucose levels, but also will reduce their hemoglobin A1C. And in those patients who haven't tried to modify their lifestyle, they will tend to be less successful after bariatric surgery, in my experience. And so I think it's reasonable to give that at least 6 months of intervention. And most bariatric referral centers will tend to require this even before having patients undergo bariatric surgery. But that being said, once we add medications, and again, I'll typically add metformin first, and very shortly thereafter, especially in the morbidly obese patient population with a lot of obese comorbidities, I'll add in a GLP-1 agonist because of its weight-losing effects. We can't predict which patient population will have a dramatic weight loss, but we will see significant weight loss in some patients on this agent, and oftentimes that's enough weight loss that we don't need to turn to bariatric surgery. But in that patient population who I've been working with them with lifestyle, I've been working on them with medications to get their diabetes under control. And I have been able to do so, especially if their A1C stays well above 7%. And in the setting of multiple comorbidities from obesity, I will oftentimes go ahead and refer them for bariatric surgical evaluation. As with any intervention that we have with patients, it's important to involve them in the decision-making process. So additional questions. So the next question is are the improvements seen in lipids and blood pressure with bariatric surgery due to factors other than the weight losses seen with the procedure? This has not been as well teased out, but certainly the improvements in cardiovascular risk factors is welcomed after bariatric surgery. It's not clear whether or not there have been changes in a number of the hormone systems in the body, a number of the cytokines and adipokines that improve following bariatric surgery, whether these may also improve lipids and blood pressure, probably so. But clearly the improvements in blood pressure and in lipid profiles mirror the reductions in body weight. Unfortunately, there are no other interventions typically from lifestyle alone that achieve the type of weight loss that's seen with bariatric surgery, so we can't know for sure whether it's weight loss alone, but that's the supposition. What's interesting, what will be seen over time, what will be interesting is whether or not the improvements in glucose control, blood pressure, and lipids will also reduce cardiovascular events, and that's currently being looked at in some longer-term bariatric trials, both in patients with and without diabetes. One would anticipate that improvements in these cardiovascular risk factors would reduce cardiovascular morbidity and mortality as well. But as we've seen from other agents, that was suggested by their beneficial cardiovascular risk profile, that's not always the case. So we'll have to wait for those interventions to come out. So again, feel free if you have questions at this point to submit them. Let me just scroll through some of these questions. So a question has come in on a new agent that was just approved this past year, the phentermine and topiramate combination. Should we be going to this drug earlier in our intervention in patients with uncontrolled type 2 diabetes? So the data that's come out in patients with diabetes has been in a mixed population, so they've selected out those patients who had diabetes prior to the drug intervention and looked at outcomes. And the improvements in hemoglobin A1C, the improvements in blood pressure, and the improvements in lipids do reflect the weight loss that is seen with these agents. The improvement in hemoglobin A1C is relatively modest, so in the 0.4 to 0.5% range, as would be expected with the degree of weight loss seen with these agents. And I'm a little bit hesitant to go with these drugs too early before we see any more long-term safety studies. This medication in some patients can lead to lightheadedness. There's been an increase in depression and anxiety with these agents, seen upwards of 8 to 10%. There's some degree of nausea seen with these agents. So I think, again, as with any agent where there's a potential for side effects, we should inform patients about the potential of the side effects, make them aware of what's anticipated, both from a weight loss standpoint and from a improvement in glycemic control. But since the A1C reduction is relatively modest, again 0.4 to 0.5%, in somebody whose diabetes is quite uncontrolled, again, A1C of over 8%, this should not be considered first-line therapy. Also with agents such as metformin, where we've seen cardiovascular benefits, improvements in lipid profiles, improvements in blood pressure, that should be an agent that we should be really using first line in combination with any other potential intervention that we choose. So again, I'm waiting for, I'd like to see more long-term studies come out with these agents before using them very early on in the process of managing patients with type 2 diabetes. So again, next, let me scroll through the questions that are coming in. So there's a question about DPP-4 inhibitors and why they do not lead to weight loss. So DPP-4 inhibitors are one of the medications we use in patients with diabetes. These drugs also affect the incretin axis. DPP-4 is dipeptidyl peptidase inhibitor. This DPP is an enzyme which breaks down incretins, so breaks down GLP-1, and the inhibitor then increases the amount of endogenous GLP-1 present. And so by doing so, you see stimulation of insulin secretion, you see suppression of glucagon, and a reduction in hepatic glucose output. However, it appears that the degree of increase in GLP-1 is not enough to lead to significant stimulation of the satiety center in the hypothalamus, and so there is not a significant amount of weight change when used with these agents. And so you need higher concentrations in the bloodstream, as seen with the GLP-1 analogs, exenatide and liraglutide, before you see significant satiety with these incretin class of drugs. So next question. So next question is what should I be doing with my overweight patient who comes to me on insulin therapy alone to help with managing their obesity? So the natural course of type 2 diabetes is one of a progressive decline in insulin secretion. So over time, actually at diagnosis, patients with diabetes typically have lost about 50% of their insulin secretion. And studies have shown that over the ensuing years that there's a progressive decline in insulin secretion, probably from free fatty acid deposition in the pancreas and a further apoptosis of islet cells and loss of islet cells. Amylin deposition appears to also lead to this. So amyloid, I apologize, amyloid deposition also appears to lead to this. So the natural course of patients live long enough with diabetes, it's very common for them to require insulin. And so when we see patients requiring insulin and they stay uncontrolled on a basal insulin alone, oftentimes we'll add in prandial insulin. So I'll have patients who are referred to me on a multi-dose insulin regimen of both basal and prandial insulin, and we'll see increased rates of hypoglycemia in those patients, and we'll see oftentimes progressive weight gain in those patients. And so what I'll do oftentimes, if I want to go the medical route first, while continuing to work on lifestyle measures of healthy diet and regular exercise, I'll oftentimes, if they come to me on insulin alone, I will consider adding in oral agents to control the postprandial hyperglycemia, agents such as metformin, potentially insulin secretagogue, a DPP-4 inhibitor, or even a GLP-1 agonist. And oftentimes I've found that by doing so, I can have patients come off of insulin, the prandial insulin therapy, and less commonly come off of all insulin alone. So just as studies have shown that adding metformin to insulin will reduce insulin requirements, lead to improvements in A1C and weight loss. In patients who are on multiple insulin injection regimen, we can see the same thing with both metformin and GLP-1 agonists, and so that's something I turn to much more. In patients who are on insulin who are referred to bariatric surgery, upwards of 70 to 80% of the patients will be able to come off of insulin after their surgical procedure. So another intervention to consider in that patient population. So at this time, I would like to thank Boehringer Ingelheim and Amylin Pharmaceuticals for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CMA credits, and stay tuned for the next session, Present and Future Perspectives on Diabetes Prevention, with Dr. Apple, Dr. Blumenthal, and myself. My name is Dr. Tom Donner, and thank you for joining me.